Thank you. Thanks to the Ocular Trauma Society for this opportunity and the Scientific Committee, All India Ophthalmic Society, to speak at this forum. Traumatic deformities of the eyelids normally result from inadequate or a delayed repair of eyelid trauma. And the various deformities that can occur include the marginal misalignments, malpositions of the eyebrow, canthal displacements, traumatic ptosis, eyelid defects, cicatricial ectropion, and many more. The marginal misalignments can be corrected by realigning the ends after freshening the edges if the wound is only a few weeks old, and in older cases you may need to excise the entire cicatricial tissue. Once you reposition the eyelid by marginal sutures, you can correct the ectropion that is present or an entropion that may have been a result of previous misalignment. So you're able to give a good correction by a reapposition of the wound. Eyebrow malpositions result from misalignments at the primary surgery or a wound that was not aligned. And these can be corrected by opening up the wounds and closing the wound in its appropriate position as the lymphedema settles and the eyebrow settles in nicely. The canthal displacements such as traumatic telecanthus result from medial canthal tendon, especially its posterior crus, being detached or being associated with Naso Orbito Ethmoid fractures. The medial canthal repositioning has to be essentially done by a transconjunctival exposure, exposing the area behind the medial, behind the sac at the posterior lacrimal crest. And after that area is exposed, you can pass a good firm bite with a proline suture through the periosteum, then pass it through the medial palpebral ligament and cause an apposition to put back the medial canthus in position. Those cases with associated skin problem will need a combined Y-to-V approach and posterior fixation of the medial canthal tendon, like has been done in this case with the Y-to-V closure and a medial canthal tendon repositioning. This lady had a brow repositioning, brow malpositioning, a forehead scar, a telecanthus, anteriorly displaced canthus. We did a revision of the scar by excision of a small piece of scar. We did a medial canthal tendon repositioning, and we could get a good brow position, restore back the brow position, restore back the medial canthal position, and revise the scar at the same sitting. Those cases where there is a gross displacement downwards, you may need to combine it with a Z-plasty like this, along with a medial canthal tendon repositioning, which has been done here in order to get the canthus back to its normal position. Associated bony deformities may require either trans-nasal wiring or low-profile mini plates to be placed, because there is a bony deformity as well. So you need to have small micro plates of titanium with short screws which can be fixed there and which provide a good correction of telecanthus. So a Naso Orbito Ethmoid fracture of such a severity can be taken care of by placing some bone which will provide the position for anchorage of a transnasal wire, and you can get a reasonably good correction along with a scar revision. This girl had a bilateral traumatic telecanthus with a bilateral dacrocystitis. After a bicoronal approach, we could do an open sky DCR along with a transnasal wiring to provide her a good aesthetic and functional result. Traumatic lateral canthus displacement downwards like here, are much more difficult to manage. You need to totally open up all the attachments of lateral canthus, provide additional tissue in the posterior lamina, which was a hard palate graft here, and you can reposition the lateral canthus with a lot of work. Traumatic ptosis needs to be evaluated like any other ptosis, and you often need to do a sling procedure, but at times a levator procedure may work quite well, like in this gentleman. Lid colobomas have to be assessed like other eyelid defects to see what is most appropriate. This patient had a canthal misalignment with canthus being positioned here, and we had to open this up and do a repair. After converting the defect to a pentagonal shape, we did a tensils repair. So with the tensils repair, it was possible to get back the upper lid into normal position and to restore the position of the medial canthus as well, pre-op and post-op appearances. Cicatricial ectropion is the last entity that I am dealing with. If it is localized, then you can mobilize tissues from around by Z-plasty or a VY-plasty. Z-plasty essentially changes the position of the two flaps made with a Z when the shortest arm is the central arm, where you give the incision along the area of shrinkage. When you mobilize the flaps, you are able to correct the malposition or the shortening. The same is true in VY-plasty, where you give a V incision. Once you undermine, because it is short, it comes to lie like this, and you mobilize tissue from the two sides to close it like a Y. So an example is this, where a Z-plasty was planned in the upper lid for this ectropion and a VY-plasty in the lower lid, and after they were done, the correction could be obtained. So this is a cicatricial ectropion here and here, more generalized here. So we needed to do a YV-plasty, VY-plasty in the upper lid and a skin graft in the lower lid. So let's look at the VY-plasty, where a V incision is given first. And after the undermining has been done, you can see that the ectropion has been relieved. The scar is removed from the bed, but as you can see, the skin is coming to lie only up to this point. So we have to mobilize the skin from here, mobilize the skin from the two sides, and then close it like a Y, and that takes care of the ectropion. So this is the pre-op appearance with ectropion here, corrected by VY-plasty, corrected by skin graft, so that the ectropion is taken care of. Where there is a more generalized loss, you need a partial thickness or a full thickness graft. A gentleman who had lost one eye after chemical burns and a severe cicatricial ectropion here, which worsened by the day, we needed to do an epidermal graft, which was placed in position after preparing the bed, and after 5 weeks, after 4 months, we can see the ectropion taken care of with the epidermal graft. Full thickness skin grafts are more appropriate, usually in lower lid, where the skin is thicker, and you can place a graft for an ectropion like this to take care of the problems. Management of traumatic eyelid deformities can be extremely gratifying. It helps restore function and aesthetics, and it can help transform lives, as in the case of this young lady. Thank you very much.
Thank you, sir. Thank you very much. I've had the opportunity to work with him for about 7 years, 8 years, and his approach has been beautiful. He has already got the largest series of lid colobomas few years ago, which was about 36 cases. I don't know now what he has got. And his approach has always been that if multiple approaches are required, multiple surgeries are required, we shouldn't hesitate to give the best cosmesis. That is what is very, very important, to do it in stages and to learn from the masters like him. Dr. Shea, you had a question for?
Full thickness skin grafting for lower lid. Do you do any extra procedure to prevent the sag?
If there is an associated laxity, you do need to do that. In the upper lid, additionally, besides the graft, you often tend to do a tarsorrhaphy as well. because then you want to retain it for a period of almost 6 weeks, because you want the mobilization to be least possible, which leads to more contraction of the graft. So in the upper lid, definitely. In the lower lid, only if there is an associated laxity, I would combine it with a little lateral tarsal strip procedure.
Thank you, sir. The last talk is on behalf of Dr.